No, looks good.
Okay. All right, well, thank you. And those of you online, please feel free to participate in the discussion, ask questions, and there's a chat and a Q&A. So navigating ethical frontiers, abortion, gender-affirming care, and HIV. And I have no disclosures, and as Chris said, this is language about getting continuing education credit. So just to show you how much this is an issue, and I'm going to be talking about how recent legislation and threats to abortion and to gender-affirming care affect clinical care, obviously, but also research, since this is a research institute, and there's been work written quite a bit, which I'll allude to, about the impact on clinical care. But I think as researchers, as many of us are, it's important that we think through what we need to do in terms of research. And lest we think that this is not a contemporary issue, this is from the New York Times this morning. The far right gets its man of the house. The new speaker, Mike Johnson, is virtually unknown to most Americans, but can be expected to press a hard right social fiscal agenda. And at the bottom, there's a quote from the New York Times article: "There should be no mistaking his extremely conservative views on social issues such as abortion rights and same-sex marriage." So this is clearly where much of our country is heading, and I think it's important that we think through the implications for a lot of what we do. So there are many threats as a result of this, and as I'll come to other laws that have been passed and are pending around the country in the past few years. Obviously, there are differences between abortion and gender-affirming care. I'm going to talk about both, however, because there are differences but also important parallels, and I think that many of us, some of us work on research with women of childbearing age, some of us work with LGBTQ populations, but the kinds of issues and the kinds of responses that we as researchers need to take, I think, are similar. And increasingly, this is not just in legislatures, but also in courts. So in terms of abortion, restrictions, as I think everyone knows, in June 2022, the Supreme Court made a decision in Dobbs versus Jackson Women's Health Organization overturning Roe v. Wade. Since then, roughly half of US states have expanded abortion restrictions. 13 states have revived or adopted near total bans on abortion. Other states have set early gestational limits on abortion access and penalize anyone who facilitates an abortion. And this, of course, can include clinicians, can include researchers as well. So if a pregnant woman, as I'll come to, is in a study, if you're studying women of childbearing age and one becomes pregnant and you say, gee, I'm pregnant, what can I do? And you help out, you are liable to penalties and criminalization in certain states. Some states have exemptions for exceptions for the pregnant person's life, but not their health. In other words, if it's going to impair the woman's health, that doesn't matter. If it's going to impair her life, it may, not always. Restrictive states claim they're protecting patients, but in fact, they are really restraining patients' rights. And many of these laws have, the Women's Safety Act, it's things like that. Abortion clinics now get heavily regulated more than other clinics. It's easier to have surgery done in many parts of the country than to have an abortion, even though surgery is much riskier. And again, they're framed in using, cynically, I would say, the language of ethics, saying we're protecting women's rights, but don't believe it. Can I move this out so I can see? Is there a way to move this from here? Thank you. Okay. Okay, so this is just a map from Planned Parenthood showing that states, vary from basically the dark red is really eliminated abortion rights, severely restricted them to some restrictions, mostly accessible, but as you can see, there are wide areas of red, dark red, and dark red. Anti-LGBTQ plus laws also, as many of you know, are increasing around the country. In 2023, from the Human Rights Campaign, they reported that over 520 anti-LGBTQ plus bills have been introduced in state legislatures, which is a record. Over 220 bills specifically target transgender and non-binary people, also a record. But that's not most of them. In other words, most of them are other things, not just about trans non-binary folks. A record 70 anti-LGBTQ plus laws have been enacted so far this year, including bans on gender-affirming care, laws requiring or allowing misgendering of transgender students, also don't say gay laws, which are increasing, where in curriculum, for instance, and this is one of the things that the new Speaker of the House has championed, is that curriculum in schools should not discuss gay, LGBT issues or even mention them. And there are judicial decisions also. This is from the Supreme Court this past year in 303 Creative versus Alenis. The Supreme Court ruled 6-3 that a Colorado website designer has a First Amendment right to refuse to design websites for same-sex couples, despite the state's barring discrimination on the basis of sexual orientation. And of course, what came out after the decision is that the person alleged to have requested the website for a gay wedding did not in fact request it. So this was sort of a made up sort of scenario that was presented, and the language on the court decision from the right was about freedom of expression. So it was framed as a First Amendment issue, that, well, if I'm asked to sort of creatively do something on a website that involves my free expression, I have a right to say no. But of course, this is a wedge issue. And so this is sort of a loophole, if you will, through which to then say, see, we don't need to have except LGBTQ individuals as customers. So just stepping back, in terms of adults and youth identifying as transgender, and of course, many of you know this, recent studies, this is from the Williams Institute at UCLA last year, 300,000 high school students ages 13 to 17 identify as transgender. 45.4% or 136,000 live in states with loss or threat of denied access. 35% or 100,000 plus total transgender and gender diverse youth, which is often abbreviated, as you know, TGDY, live in states with bans on gender-affirming care. In other states, there are executive or administrative bans. In other words, the ways that the law can come out with these kinds of restrictions vary. And of course, gender-affirming care can improve well-being if individuals are experiencing gender dysphoria or distress. And again, as many of you know, mental health problems among transgender youths are higher than among other groups in the population. Rates of depression, again, there are various studies looking in different areas, but roughly they range from 12 to 64%, with the mean being around 50%. Suicide attempts, 9 to 30%, with the mean sort of in the middle there. Self-harm, 13 to 46%, eating disorders 2 to 16%. So there's a lot, as many of you know, mental health problems that gender-affirming care can help address if it's available. And again, this is from the Human Rights Campaign, just showing where there are laws or policies banning gender-affirming care. And again, it's many states, not surprisingly, it maps quite well onto the set of states that have restrictions on abortion care. And just in terms of types of gender-affirming care provided, again, many of you know this. This is a study recently, Hughes et al. From the Journal of Adolescent Health, looking at 103 providers from 50 states, what kind of gender-affirming care they provide. Prescribing hormones was 93%, prescribing menstrual suppressants 88%, anti-androgens 86%, surgery 85%. Surgery referrals, that is, prescribed puberty blockers, 81%, letter writing to support health care, 79%, mental health care, 17%. So a variety of types of interventions. So the effects of these laws, obviously, are polarization of care, decrease of care. Legislation, importantly, defies standards of care. So the American Academy of Pediatrics, the American Academy of Child Adolescent Psychiatry have all very strongly come out saying standard of care should be to offer gender-affirming care because of the mental health and other effects. And so these laws very much stand in the way of medical standards of care. And I'll come back to that later about ethically and from a policy point of view, when should the government dictate what providers can and cannot provide when it goes against a standard of care that providers have established based on scientific evidence and clinical evidence. So the effects also are to worsen the health of transgender and gender diverse youth and their families, worse mental health, increasing suicidality, worsening discrimination, also adverse effect on providers. As I mentioned, there are legal and personal threats and also moral distress if you are a provider, either for women seeking abortion or for transgender and LGBTQ care. Now, interestingly, if you look at what the opponents of gender-affirming care are saying, they're saying that they are protecting minors from unsafe experimental treatments. So again, they're using the language of ethics to say that this is to avoid risks, rather than saying this is just an attack on LGBTQ people, let alone that it's sort of politically motivated to sort of get the right voters on the right, that is, to vote in protection. So they say they're protecting minors from medical procedures that the minors can't undo. There are detransition stories that get publicized. So there are articles that get picked up by the media. What I needed was a shrink, not a bilateral mastectomy, for instance. And these get publicized and promulgated far more than they are representative of the population at large. And I should say that though there are stories of regret, there are stories of regret with lots of surgeries, lots of treatments. People saying, you know, I wish I didn't have the chemotherapy, it didn't really extend my life as much as I would like. So the notion of regret alone is not new or distinct to this area, et cetera. I think it does show that there's a need to empirically study how often regret happens, but it's not nearly the rate at which you'd think looking at the news stories, particularly on conservative media. Moreover, if states really want to protect adolescents, if that was really their intention, these laws could be framed differently. They could not have a categorical ban, but they could have enhanced informed consent. In other words, if you're really concerned about protecting people from getting treatments that they don't want, you could say, well, we're going to have a really robust informed consent so that they really understand what they're getting into, et cetera, et cetera. You could assess the duration of gender dysphoria. You can say, in other words, well, you know, given that there are concerns about that patients may regret this, we just want to see if they've had gender dysphoria for 3 years or whatever it is, or sort of really make sure they've thought the issues through. Of course, state bans also violate the rights of parents who support gender-affirming care for their offspring. So again, you know, parents have autonomy here, and so if parents say, just like women making a decision about their own body, if a parent says, you know, I'm the child's guardian and representative, and I have the child's best interest, and providers agree with that, that ethically should justify providing gender-affirming care. Also, evidence is needed to justify, with the opponents of gender-affirming care say, well, we need more evidence to justify provision of care. In other words, well, we just don't have enough evidence to know that gender-affirming care is worth providing. But of course, the opponents are banning abilities to fund or conduct such research. So you could say, well, we need more research first, but if you don't allow any research to occur, you're not going to have the research. If they really thought we needed to get more research, you'd think they would say, well, let's first fund research, which they're not doing. They also argue, well, Europe is also banning care. It's not just the United States, but in fact, while some European countries have restricted care, they're allowing it in clinical research context. So Norway, for instance, has similarly said, well, we're going to restrict gender-affirming care because it's controversial, but we allow it in research context, in clinical research context, so it basically still goes on. So saying, well, Europe is banning it also is not really a justified argument. The thing I really want to focus on for us today are the implications for research, which has gotten relatively less attention. Given there are legal obstacles, including ambiguous laws and fears of criminal prosecution for conducting research, either on women of childbearing age or on LGBTQ plus individuals. So there are fewer clinicians and researchers who are able to conduct the research on relevant issues. Fewer are interested in conducting research because there are researchers around the country who say, you know, I'd love to do work in this area. Often they're an LGBTQ person themselves. They'd say, I'd love to do this, whether they're a sociologist or even a historian, but they are advised and they sense they should just not go there. This is too controversial. So if you're, I recently spoke to a historian of sexuality who said that across the country there are historians who want to study this as an area and are afraid to do so, because if they're in one of the majority of states where this is taboo, so to speak, or there are laws against this, this could prevent them from getting hired by universities. And as many of us know, the governor of Florida, I won't mention his name, and others are getting involved in what is the curriculum even in universities and saying, you know, there are certain areas that should just not be taught, et cetera. These are, you know, bad areas. We're certainly not going to give someone tenure who this is their area of research. So there's a lot of effects. And of course, we need to get training on the needs of relevant populations in order to conduct research on them, et cetera. Now, so for anti-abortion laws, this has several sets of implications, and many of you work with women of childbearing age, but there's research just on women who could become pregnant during research. There's implications for staff or participants, but also therefore for the social and scientific value of some research. So if people are just not able to do research on women of childbearing age, we know less about this population. This has major public health implications. And of course, research participants, even if you're not studying pregnancy, but just women of childbearing age, they could potentially become pregnant. And in research, this is often a challenge and I'll come to this in a moment. Research interventions, let's say we're just studying a chemotherapy or a blood pressure medicine on women of childbearing age as part of the population. It could expose participants to unknown risks. There could be threats to their health or the life of a pregnancy or a fetus. In research on certain drugs, abortion may in fact mitigate research-related harms. If I find that I'm on a chemotherapeutic agent as part of a study and now I become pregnant, it may be that abortion makes sense just for given the effect of the research itself. So there's a number of research studies, as some of you know, that can require participants to undergo periodic pregnancy tests. We're studying women of childbearing age, and we just want to make sure they're not pregnant because we're trying out a new drug that hasn't been tried on, you know, children or fetuses, et cetera. So there are studies that might detect and document early pregnancies that otherwise would have gone unnoticed, given high rates of miscarriage. It might raise concerns that the participant obtained an illegal abortion. So if we're just asking what's going on, you know, any changes recently? Well, I had an abortion 2 months ago since I last came to you as a researcher because I got pregnant. Well, then you have that information, and what happens to that information? You know, is it turned over to the state? Are you required to report it? So again, people who become pregnant may become pregnant get underrepresented in studies. Researchers may become reluctant to obtain data on pregnancy. So even when they should be obtaining it, they say, well, we just won't ask about it. So we're going to study this new cardiac drug, and we're just not going to ask if women have gotten pregnant, or because then we get stuck with this information. And of course, it's possible medications may have toxic effects on fetuses, or we just don't know, et cetera. Staff may face legal risks with laws that penalize those who facilitate abortion, referring a participant to an abortion provider out of state. So if you're in a study and a woman says, well, actually I just became pregnant, can you help me find, where can I get an abortion? We're here in Texas. Well, if you even say, well, you could, you know, fly to New York or whatever it is, or here's the name of someone in New Mexico that's closer or something, you can be prosecuted. So in general in ethics, we believe that research-related risks should be minimized, and other risks in clinical care should be minimized and reasonable in relation to the scientific and social value in research. And this has potential implications for research site selection, where you're going to do the research, managing these studies, study design, implementation. So you need to, for instance, and this is research both for women of childbearing age, but also on LGBTQ plus individuals. Increasingly, we need to assess current laws. Unfortunately, laws are not only restrictive, but also in flux. They vary. There can be penalties for referral. There can be citizen enforcement. So it could be even that, well, I heard that you offered an abortion to this person or offered gender-affirming care, and therefore I'm reporting you. So it's important to get local legal expertise and interpret local laws. So this is something that many of us researchers have not usually done, but now need to make sure that we and our IRBs have. It's important to evaluate site experience, explore staff experiences. Have staff, in fact, been running into these issues? Is this a source of distress? What have they been doing? What's the likelihood that laws will be enforced legally? Again, there could be, though, changes in a governorship or something, so there may be a law in the books that's not enforced and then becomes enforced. Have there been any problems encountered thus far? If so, what can be done? Stakeholder engagement is obviously very important, to work closely with local staff. have research staff and or participants express concerns about this, and to sort of note the concerns, to be able to deal with them, I think is important, both in a study, but also I think to publish about this, write about this, so researchers at other sites can know what's happening on the ground. Community engagement, if you did engage a community, who was included, site suitability, what if any legal restrictions may affect the study, again, risks to research staff, participant, and our fetuses. Should you modify the research, and if so, how? So I think the question of, especially as these laws are now increasingly on the books and changing, many of these laws, as we saw, have been proposed but not yet enacted or not yet passed, but they're in various state houses in various states of play. So it's important to be aware and to think through, do I need to change my research on LGBT individuals, on women of childbearing age? Sometimes it means not pursuing research at a particular site, but then that obviously prevents the opportunity for people who could participate, whether they're LGBTQ or women of childbearing age, et cetera. So, and again, some of these considerations are more for abortion than for LGBTQ rights, but again, so many of them are similar, I thought I would sort of list them together. So for abortion, obviously, as I've mentioned, there are provisions for abortion access are important. What plans are in place for participants who become pregnant? So I think research studies need to think this through in advance to now think through, if the study started before 2002, when Roe v. Wade was overturned, if studies need to decide if someone comes in and says they got pregnant, what do we do? And to think this through. Prepare staff if those who facilitate abortion access face legal risk. Again, some studies are already underway and now have to think about this. And again, this needs to be revisited if the legal landscape changes. Confidentiality as part of study design and implementation is obviously important. There may need to be, probably will need to be, special provisions for data privacy regarding pregnancy tests, access to abortion services, and gender-affirming care. Consider these issues during the design and implementation of data collection and management. So if we're going to get this data, what do we do with this data? If we have data that someone is seeking or wants gender-affirming care or needs an abortion or is thinking about it, do we store that data with the rest of the data? Do we not store that data? Do we put it somewhere else? Do we not even ask? Again, these are questions I think need to be considered. There are certificates of confidentiality that the NIH gives, but they've never been tried in court. So they're nice to have, but the meaning of them is not clear. And if you're in one of those red states, it probably won't hold much water. It may very well not. You maybe maintain links to data elsewhere, encrypt the data. I think there are data security measures one could take, keep this data in some other state, for instance. And again, despite HIPAA, entities might disclose information in the event of legal action. They may be required to disclose information. So again, I think these are very scary times. I think provisions to reduce and manage the risks are important, to develop approaches to manage also economic risks. So if these are LGBTQ individuals and they can't participate in research and you're doing research on them, to understand, what kinds of economic harms are they facing, what kind of social harms. I think to gather this data is important for us to know. You may need to modify study designs or standard operating procedures. Again, whether to regularly assess pregnancy during the course of research. Should you frequently test for pregnancy, as one had? Do you say, well, just self-test for pregnancy and don't let us know, or only let us know if it's positive? Or again, these are considerations that studies may need to consider. Ensure access to contraception also can be increasingly important. Maybe we didn't ask this before when it was easy for a woman to get an abortion. Now, if we're conducting a study and the woman is of childbearing age, we want to maybe make extra sure that they have contraception available, et cetera, so that they don't have to sort of go down this line. Of course, contraception itself is getting restricted in certain ways or under threat, but FYI. So again, in informed consent for women of childbearing age, for instance, we arguably need to include the risks, both physical, social, legal, and economic, to themselves and their fetuses in the consent form. So we may need to sort of revise consent forms or reconsent participants. Also with LGBT individuals, I think considering, do we need to revise the consent form given that there are now these new laws coming onto play? And if so, how should we revise them? include access to contraception to avoid pregnancy in the study, include awareness of states' abortion restrictions or LGBTQ restrictions in the consent form is something we may need to do. Again, monitoring for social harms, I think asking participants at study visits about the harms, physical, social, legal, economic, that they've had associated with abortion access or getting gender-affirming care, undesired pregnancies. Partners may also face harms. Women of childbearing age, but also other LGBTQ individuals, if you have a partner who is interested in or getting gender-affirming care, and now you have that data as a researcher, what do you do with that data? To think that through could be an issue. And to be aware that they may also face harms. And of course, researchers do have ancillary care obligations. So I would say that in research, we don't have the full obligations to help patients as if we were that patient's clinician, but we do have responsibilities to help patients in a study as much as possible. And so I think that trying to assist with access to care if it's needed, if it's a standard of care, is something we should try to do if we can. I think IRBs need to play a role here, obviously, to assess risks related to restrictions on abortion and gender-affirming care. As many of you know, the past few years we've had a system of single IRBs in which the NIH mandates that for multi-site studies, there needs to be a single IRB of record rather than have 20 different IRBs deciding and evaluating a proposal, a protocol. There should be a single IRB that makes a decision so that there's less discrepancy between IRBs. But that means that there may be a single IRB in New York that's making decisions about study sites that are in red states. And so that poses problems for single IRB process. Does a single IRB know what the state of affairs is in all those different states where, again, legislation is changing? And I should say that in some of these states, there are court challenges that LGBT advocates and women's advocates have raised. There is a very complicated back and forth going on in the courts at the moment. For instance, Arkansas, there was, and Oklahoma and some other states, there was a very restrictive law. Opponents challenged it in court and won. Then it's been now appealed and maybe reappealed. And so again, this is a very shifting landscape. And I think it's important to be aware of the uncertainty, but it's really shifting as we speak. And one doesn't know what the outcome will be. Obviously, it depends on who the judge is and where the court is, et cetera. So IRBs need to consult with appropriate expertise and do this well. IRBs face a number of challenges, as many of you know, but so this is extra work for IRBs that hopefully institutions will give them resources to do. During continuing reviews, IRBs should also require information about changing laws. So it may be, although it's extra work for the investigator in a continuing review to say what's changed, you may need to say, well, there's now laws restricting access to abortion or contraception or LGBTQ gender-affirming care, and that can affect the context and therefore the risks to participants in studies we're conducting. DSMB should also consider safety related to restrictions on abortion and gender-affirming care. You may have stop rules. It may be that you need to say in a certain state we can just no longer go forward with this research study. Obviously that means weighing complicated risks and benefits because there are obviously sort of some risk to participants, or participants may lose out and they're no longer being in a study from which they were getting some benefit. But I think the risks may outweigh the benefits. So again, these may be complicated trade-offs. So again, it may be necessary to conduct research elsewhere to, I think, also generate best practices. So this is sort of a very high-level view. And I think that we really need data on, and I think it's important for researchers to communicate about and write about, for instance, publish about, what experiences are on the ground. And what should be done for some of these questions. In other words, when should you reconsent someone, et cetera? What should you put in the informed consent about some of these legal risks? And again, collecting data, how often challenges due to abortion restrictions or gender-affirming care arise, how they're being managed by researchers, how they should be managed. I think obviously there's need to educate researchers, IRBs, and policymakers. I think policymakers should consider the potential negative impact on research on women of childbearing age and gender-affirming care. So a lot of, I think, policymakers may not think, for instance, they're saying we need evidence, but we're not going to let you get the evidence. That sort of defeats their own argument. Also they may focus on, well, quote, abortion is murder, not thinking through the issues and understanding that this is going to affect our understanding of the health of women of childbearing age, even if those women themselves are anti-abortion. In other words, we're just going to lose out knowledge about a wide percent of the U.S. population. With gender-affirming care, so there's obviously similarities with abortion restrictions. Again, I think number one is just really ensuring that staff receive training. Also, some researchers have conducted Know Your Rights workshops for patient populations to really educate patients who may not be fully aware of some of the restrictions, what the implications may be for themselves. Engage with public interest law groups and other community groups. Consider other issues and costs. There's also, for instance, undocumented youth who are seeking gender-affirming care, though that's been less discussed in the case of abortion, but I think that raises another set of issues in terms of keeping data and data protection, et cetera, that need to be considered. Confidentiality, obviously, here is important as well, and so considering other modalities for intervention delivery or follow-up assessments, doing it all online, for instance, and so the data also could be stored elsewhere, revising informed consent, as I mentioned, providing patients and parents with legal support, maybe something that researchers may need to do more than they now are doing, assistance for families with legal name and gender changes, offer support, engage with community organizations, assisting with community resilience, organizational resilience of LGBTQ advocacy groups, I think is something researchers can do or needs more attention or et cetera, more, and this has been done quite a bit, but even more than it's done in the past. And as I mentioned, I think this is an area important for scholarship and research to assess and document the impacts on bans on treatment for mental health, for physical health, on levels of stigma and discrimination, the ways in which research can't ideally be done, and so the social and scientific benefit of the research is not going to be as high and robust as it otherwise would have been. And as I mentioned, there's some larger questions, ethical versus legal claims. So society has historically given physicians and providers discretion to provide treatment and do research based on ethical principles. In other words, we basically said we're not going to have laws regulating everything doctors do. If I can give you this dose of medicine versus that dose, we're going to have doctors and providers follow the Hippocratic Oath or the equivalent, realizing that healthcare is not a good that we sell in stores like we buy and sell computers or shoes or paper, but is something that requires trust, that requires confidentiality, and of course that goes back all the way to the Hippocratic Oath. And so now these laws are violating that, and the ethical principles that I've mentioned, obviously, and that are important are patients' autonomy, beneficence, minimization of risks, and social justice, and distributive justice, and access to care being important. But I think there are larger questions. Should the state have the authority to regulate medical practices? If so, when and how much, and who should decide? I think these laws very much go against thousands of years of medical ethics, which advocate that providers have discretion and that confidentiality is important. And I think these are problems. So I just want to thank some folks I've spoken to who have been very helpful, and my assistant Patricia helped with the slides, and I'd be happy to answer questions. I realize I ran over a lot of material here.